Hello everyone, welcome to my YouTube channel, Holistic, Palliative and Pain. Our topic today is pressure ulcers in pain and palliative setting. These are the objectives of our presentation. Prevalence. Pressure ulcers are highly prevalent among older adults and elders receiving palliative care in numerous care settings. A palliative care approach to wounds involves a comprehensive assessment of existing wounds and prevention of new wounds. In USA, 3 million per year in palliative care. Majority of patients do so in the last 7 to 14 days before death. Etiology of pressure sores are basically three things. Pressure of bone against hard surface, pinching of blood vessels, friction of skin against surface. Again, the causes of pressure ulcer development. As you see, pressure, forces, friction, forces, and shear forces. And that is why pressure ulcers show up in certain areas of the body. This is kind of a summary to pressure ulcer causes: immobility, bowel and bladder incontinence, shearing and friction forces, malnutrition, obesity, history of pressure ulcers, dehydration, contractures, lack of compliance and use of diapers, and excessive skin moisture. And on the right, it shows you the areas that always get affected. Poor attention to skin care in the dying patient will result in pain, odor, swelling, reduced quality of life, and increased care demands for family and other caregivers. Skin can withstand 30 to 60 minutes of poor perfusion, but not longer. Pressure ulcers result from ischemia due to pressure closing the microarterioles, particularly at pressure points such as the heels, sacrum, and elbows. Intrinsic risk factors for ulcer development are limited mobility, conditions that reduce tissue oxygenation, age-related changes in the skin, and cachexia. Extrinsic factors are physical forces such as friction, moisture, and shear force. Prevention of ulcers is the highest level of care. Bedbound patients need to be turned regularly and/or need a pressure-reducing surface. Skin should be protected from friction, moisture, and shear. High-risk areas should have either a thin film or hydrocolloid dressings applied. Early involvement of a wound care specialist is recommended to assist with education, ongoing assessment, and dressing choices tailored for the patient's unique circumstances with regards to comfort, cost, wear time, prognosis, and wound characteristics. Ulcer progression. We have four stages for ulcer progression. Starts with a stage 1, which is basically heralding the lesion of the skin ulcer. Ulceration is non-blanchable erythema. And that's why, as a physician, you should pick up the stage 1, so you start your prevention measure, so you don't get into stage 2, 3, and 4. Stage 2 is a partial thickness skin loss involving epidermis, dermis, or both. The ulcer is superficial and looks like an abrasion or shallow crater or blister. Stage 3, full thickness skin loss involving subcutaneous tissue. The ulcer may extend down to, but not through, the underlying fascia. The ulcer looks like a deep crater with or without undermining of adjacent tissue. Stage 4 is an ulcer that's deep enough to include necrosis and damage to underlying muscle, bone, and or supporting structures, such as tendon or joint capsule. Undermining of adjacent skin and sinus tracts may be also present. Again, stage 1, 2, 3, and 4. There's another 2 additional stages that we also sometimes refer to. One of them is unstageable. And in this situation, we have a presence of a slough or eschar that obscures the depth of the ulcer, or what we call suspected deep tissue injury. Usually there's a purple or maroon discoloration of the intact skin. I'm going to show you some pictures for different stages. Stage 1, non-blanchable erythema. Stage 2, partial thickness skin loss with intact dermis. Stage 3, full thickness skin tissue loss. Stage 4, full thickness skin tissue loss. Unstageable is full thickness skin tissue ulcer with unknown depth. Suspected deep tissue injury, depth unknown. Pressure ulcer prevention. Repositioning, pressure redistribution surface, risk assessment scales such as the Braden scale, risk factors, early identification and intervention, emergency department early assessment and intervention, and lastly, education to patient and family. Treatment. Once a pressure ulcer has developed, immediate treatment is required. In choosing a treatment strategy, consideration should be given to the stage of the wound and the purpose of the treatment. That means protection, moisture, or removal of necrotic tissue. The treatment strategy that's used is highly individualized for each person based off his or her health status, diagnosis, size, and site of the pressure ulcer, and the stage of the pressure ulcer. The treatment is based on 4 categories here. First category is reducing the pressure, such as repositioning and using support surfaces. Number 2 is cleaning and dressing wounds. Number 3 is removing the damaged tissue through surgical mechanical, autolytic, or enzymatic debridement. And lastly is other interventions such as pain management, antibiotics, healthy diet, management of incontinence and muscle spasm, plus negative pressure therapy and surgery. Reducing the pressure is done through repositioning. If you have a pressure ulcer, you need to be repositioned regularly and placed in correct positions. If you use a wheelchair, try shifting your weight about every 15 minutes or so. Ask for help with repositioning every hour. If you are confined to bed, change positions every 2 hours. Using support surfaces such as mattresses, bed, and special cushions that can help you lie in an appropriate position, relieve the pressure on any sores, and protect vulnerable skin. Pressure reducing surface. We have 3 examples here: air or water, mattress overlays, low air loss beds, or air fluidized beds. And these are examples of such pressure reducing surfaces. Simple foam pads are also used. They are often ineffective, but they can be utilized in certain conditions. Never use round cushions, such as donuts. They can occlude blood flow. And you're probably going to need professional assessment with special pressure reducing cushions for wheelchairs, for example. Simple foam pads, such as silicone foam dressing. Cleaning and dressing wounds. Cleaning is essential to keep wounds clean to help prevent infection. If the affected skin is not broken, a stage 1 pressure ulcer, gently wash the area with water and mild soap and pat dry. Applying dressing promotes healing by keeping the wound moist, creating a barrier against infection, and keeping the surrounding skin dry. Example for dressings are the hydrocolloid dressing or the alginate dressing. Removing the damaged tissue is the third category of treating pressure ulcers, and this is done through surgical debridement, mechanical debridement, and this is usually done through a pressurized irrigation device, or autolytic debridement using enzymes to break down the dead tissue. And this could be used in smaller uninfected wounds. Enzymatic debridement involves applying chemical enzymes and appropriate dressings to break down the dead tissue. Other interventions such as pain management, antibiotics, and healthy diet. We'll spend some time on pain management. First of all, you have to understand that this type of pain is a mixed type of pain. It's nociceptive and on the same time inflammatory and also neuropathic. So you're probably going to end with a combination of different medications to help with the pain management, such as opioids, antineuropathic agents such as gabapentinoids and anti-inflammatory drugs whenever possible to reduce the inflammation. One of the things that you need to know about is topical opioids. When you have a tissue injury, you start to have opioid receptors proliferating in the periphery. And this is the role of topical opioids. And this is usually done through preparing morphine gel by mixing some morphine, like 10 milligram morphine, with a standard gel formulation, and putting it on the wound 3 to 4 times a day. And this is very useful, especially if the patient has side effects from the opioids or systemic opioids. Antibiotics. Antibiotics are basically used when when there is a resistance to all kind of therapies that we tried here. It's not our first choice. Healthy diet is also important since you need to increase the protein in your patient's diet, and also adding some supplements such as vitamin C and zinc. Management of incontinence. Urinary or bowel incontinence may cause excessive moisture and bacteria on the skin, increasing the risk of infection. Muscle spasm relief is also important because of the spasm-related friction or shearing can actually worsen bed sores. So you can add this to the pain management, or you can put it as a separate entity here. But you're probably gonna need to add some muscle relaxants to your pain combo here that you're using. Negative pressure therapy, such as vacuum-assisted closure or VAC. This therapy uses a device that applies suction to a clean wound. And lastly, surgery here for pressure ulcer that fails to heal may require surgery. This is the wound vacuum. We'll jump into important topic for palliative physicians, which is the Kennedy terminal ulcer. What is Kennedy terminal ulcer? It's originated from Miss Karen L. Kennedy, who was a nurse that described these pressure ulcers that appeared just before a patient's death. She described them as the purple areas on bony prominences, particularly on the sacrum, that preceded death by 2 or 3 days. That's why we now call them a deep tissue pressure injury. However, not all deep tissue injuries signal death. The Kennedy terminal ulcer is predominantly found in geriatric and terminal population. Statistics report that more than 50% of these ulcers develop at the end of life in older adults. Potential causes and characteristics of a Kennedy terminal ulcer. These are several theories on the causes of Kennedy terminal ulcer. One theory is reduced blood perfusion. Another theory is since the skin is the largest organ, it can reflect what's going on inside your body, such as internal organs slowing down, followed by multi-organ failure. The Kennedy terminal ulcer usually manifests as a superficial large ulcer that has sudden onset and progression as person is dying. The ulcer will then deteriorate quickly with depth and devitalized tissue such as slough and eschar. It is important to remember the presenting characteristics can sometimes vary from patient to patient. The most important is the location of the ulcer. It's a sacral ulcer, and the timing is usually in the last 7 to 14 days of life. Assessment is based of Kennedy ulcers based on location, shape, color, onset, and borders. Kennedy terminal ulcers may begin with appearance of a bruise and then rapidly decline into a full thickness ulcer. Treatment options of Kennedy terminal ulcers and wounds at end of life is no different than other, types of pressure ulcers that we deal with in our daily practice. However, the focus is on quality of life more than really reversing the ulcer. So the main focus is on pain management, and also make sure that about dressing changes, so these ulcers do not progress as much as you can, of course. Okay. Lastly, we're gonna talk about diabetic ulcers, and this is a very important topic for pain physicians. I've seen many of these patients in my pain clinic for pain control, of course, more than treating the ulcer itself. Anyway, diabetic ulcers is very common. 18.6 million people worldwide are affected by diabetic foot ulcer each year. And diabetic foot ulcers are categorized using the Wagner-Megget classification. Grade 0 means no break in the skin. Grade 1 indicates a superficial ulcer. Grade 2 indicates a deep ulcer. Grade 3 shows the presence of osteomyelitis. Grade 4 is identified as a forefoot gangrene. And grade 5 is recognized as a complete foot exposure to gangrene. Wagner-Megget classification from grade 0 to grade 5. Again, the pathophysiology of pressure ulcers in diabetics. It starts with peripheral neuropathy, sensory motor autonomic, and peripheral arterial disease. Also, like we mentioned previously in pressure ulcers, mechanical pathways such as continuous stress, repetitive stress, high stress, all of these reduce the blood flow, plus the vascular pathway, because of the reduced peripheral arterial supply, which can cause all of these can cause foot ulcer development. There are clinics that deal only with diabetic foot ulcers. They check your usual, the shape and the stage of your diabetic foot ulcer. They usually check also Dopplers on both lower extremities to look at your blood flow, make sure your diabetes is under control, and they manage these ulcers according to the staging. Neurological, vascular, and biomechanical factors contribute to diabetic foot ulcerations, as we mentioned. The 5-year mortality rate for individuals with a diabetic foot ulcer is approximately 30%. People who are Black, Hispanic, or Native American, and people with low socioeconomic status have higher rates of diabetic foot ulceration and subsequent amputation compared with white people. Classifying ulcers based on the degree of tissue loss, ischemia, and infection can help identify the risk of limb-threatening disease. Several interventions reduce risk of ulcers compared with usual care, such as pressure-relieving footwear, foot skin measurements with offloading when hot spots are found, and treatment of pre-ulcer signs. Surgical debridement, reducing pressure from weight bearing on the ulcer, and treating lower extremity ischemia and foot infection are first-line therapies for diabetic foot ulcers. Randomized clinical trials support treatments to accelerate wound healing and culture-directed oral antibiotics for localized osteomyelitis. Multidisciplinary care, typically consisting of podiatrists, infectious disease specialists, and vascular surgeons, in close collaboration of primary care clinicians, is associated with lower major amputation rates relative to usual care. Approximately 30 to 40% of diabetic foot ulcers heal at 12 weeks. We're going to end our presentation with two multiple choice questions. I think these are very relevant to our presentation here. First one is a 76-year-old man with metastatic nasopharyngeal carcinoma, now with poor functional status, and spends most of his time in bed. On examination, he has developed a shallow crater on his left buttock, which is involving the dermis. There is no exudate, and deeper structural subcutaneous tissues do not appear to be affected. He is advised to improve his mobility and use air mattress. Which of the following therapies will be appropriate for him? The correct answer is E, hydrocolloid dressing. Hydrocolloid dressing is the correct option. This patient developed grade 2 pressure ulcer with no exudate. This dressing will form an occlusive barrier over the ulcer, retain moisture to promote rapid wound healing, and also prevent bacterial contamination of the wound. It also acts as a barrier against friction and shearing injuries by forming a soft gel between the wound and dressing. Surgical debridement is incorrect. It's reserved for patients with grade 3 to 4 ulcers. Oral antibiotics is incorrect because they are given to patients who do not respond to conservative measures, or those having an ulcer with a necrotic base with associated osteomyelitis or cellulitis. Local antibiotics may be used instead. Wet to dry dressings, incorrect because it's reserved for wounds with a high degree of bacterial contamination. Alginate dressing is an incorrect option because also they are highly effective at treating pressure ulcers. They should not be used in dry or minimally draining wounds, as they absorb moisture and prevent wound healing. I think this multiple choice question kind of wrapped the whole topic. And another question, which they love to bring it in the board exams. A 50-year-old woman presents with complaints of extremely foul odor from a lesion on her left breast. She explains that the pain is treatable, but the odor makes her nauseous. And other people also stay away from her. So it's disturbing. She has a medical history of advanced breast cancer with an erosion of the overlying skin with a short life expectancy. Local examination showed an ulcerated lesion, draining pus with a foul odor. Which of the following is the best way to address this patient concerns? Lidocaine gel, morphine gel, palliative radiotherapy, D, sprinkle crushed metronidazole on the wound, E, is surgical debridement. The correct answer is D, sprinkle crushed metronidazole on the wound. Explanation. Sprinkling crushed metronidazole on the wound is the single most effective measure of reducing the odor from the wound. Lidocaine gel is primarily used to reduce pain. Morphine gel is the same for pain management. Palliative radiotherapy is indicated if the patient is experiencing intractable pain, which is not the case in this scenario. Surgical debridement is not appropriate measure as the patient has a short life expectancy. Moreover, surgical procedure is not considered when the odor is only concern to the patient. Key learning points of this presentation: pressure ulcers are highly prevalent among older adults and elders. A palliative care approach to wounds involves a comprehensive assessment of existing wounds and prevention of new wounds. Poor attention to skin care in dying patients will result in pain, odor, swelling, reduced quality of life, and increased care demands for family and other caregivers. Pressure ulcers result from ischemia due to pressure closing the microarterioles, particularly at pressure points such as the heels, sacrum, and elbows. Kennedy terminal ulcers predominantly found in the geriatric and terminal ill patients. Statistics report more than 50% of these ulcers develop at the end of life in older adults. Diabetic foot ulcers affect around 18.6 million people worldwide each year and are associated with increased rates of amputation and death. Thank you.